Good afternoon, everyone. Thanks so much for coming today. I'm Jody Barkin in the Division of Digestive Health and Liver Diseases, and it's my honor to be able to introduce our named endowed lectureship. This is the Jamie Barkin Lectureship in honor of Jamie Barkin, who has been our longest serving faculty member in the history of the division, and really was a leader in our field in pancreatic and small bowel diseases, in the field of gastroenterology as a whole. Today's lecture is brought to you in part by the generosity of Linda Corey, Stephen Elias, and Perry Lee Roberts, who have made significant efforts to support the educational endeavors of our department. And today we have a true treat in Vivek Kaul, who I won't belabor the introduction, but he's a really amazing colleague, mentor, and friend, and really a visionary leader in our field. And with that, thanks so much for coming, my friend, and I will leave it to Dr. Gadapati.
Good afternoon, everyone. My name is Srisha. I'm one of the Jackson Chief Residents, and it's really my pleasure to introduce Dr. Vivek Kaul, who is a professor of medicine and former division chief in the gastroenterology and hepatology division at the University of Rochester Medical Center. With nearly 25 years of experience in academic gastroenterology, he completed medical school at Delhi University, followed by residency at SUNY Downstate in Brooklyn, GI fellowship at Albert Einstein Medical Center in Philadelphia, and advanced training in therapeutic endoscopy at St. Luke's Pancreatico-Biliary Center in Milwaukee, where he specialized in ERCP and EUS. His clinical research and educational work focuses on therapeutic endoscopy, Barrett's esophagus and esophageal cancer, and pancreatico-biliary diseases, and he has served as a principal or co-investigator on numerous national and international trials, including NIH-funded studies. Dr. Kaul is a prominent leader in global gastroenterology, currently serving as president-elect of the World Gastroenterology Organization, and holding key roles within the AGA, ASGE, and ACG, including vice chair of the AGA Council section of Endoscopy, Technology, and Imaging. He also serves on several national and international task forces, including the WGO Climate Change Green Endoscopy Task Force and the ACG Ergonomic Task Force. In addition, he currently serves on the EUS and research subcommittees of the GI Quick Consortium. He has published nearly 120 peer-reviewed articles, serves in editorial roles, including an associate editor for ASGE's Innovation Journal, and the International Editorial Board Chair for the ACG Journal Clinical and Translational Gastroenterology. He is also Castle Connolly's top doctor for 10 consecutive years. Please join me in warmly welcoming Dr. Kaul.
Thank you very much. That was already some time lost, but very, very kind introduction. Very honored to be here at the kind invite of Dr. Jody Barkin and the leadership of the Division of Gastroenterology and the Department of Medicine. Dr. Weiss, nice to meet you. For me, this is a deeply personal visit, as many of these are, because I have many friends from before. Fabian is here, and Dan Sussman, and many, many others, Amar as well. But I've seen Jody's career grow, and what a wonderful treat to see the division coming together, and excited particularly to see another great colleague of mine, Field Willingham, who's coming in to take charge and lead this division to greater heights. So for me personally, deeply emotional and a very productive visit. Great conversations with our APP leadership here, Carol and Takara, and more good things to come. Dr. Jamie Barkin, although a legend and a person of that I'm not qualified to even comment on, but had the great fortune and privilege of making his acquaintance and becoming a remote mentee friend over the years. So this is a particular honor to be here and to speak to his legacy under the umbrella of this endowed lectureship. The first slide, I felt, therefore, was very appropriate to have a little reflection on Dr. Barkin's life. He was magna cum laude at the University of Miami and was in the Hall of Fame at the Miller School of Medicine here. Many titles, of course, Chief of GI, President, Professor Emeritus. But the one thing that from the very beginning when I met him several years ago that stood out to me, that he was also an equally decorated Army official in the reserves. And in fact, we had many conversations around that as well. So for me, this is not only a role model, but really a mentor, a living legend, and a true icon. I had the great pleasure of being at this major award ceremony, which is the ACG Burke Fies Award, given for exceptional distinguished clinical excellence in practice clinical research over a long period of time. This is not an award that the college presents very lightly at all. So that was his award, and this was my award from him. This is a challenge coin that he received in his time in the Army, and probably one of the most precious gifts I've ever received in my life in cash or kind. As we understand now, this activity, this time that he spent in the Army, we see now in today's world where these type of engagements, this investment that people have made, whether fully in the forces or partly in the medical reserves, we salute them, especially in these difficult times. So I wanted to reflect a little bit first before coming to the meat of my topic here, because this is so deeply personal as well. Now, one of the great privileges I have nationally as well as internationally when I visit centers of excellence such as this one is to really reflect upon also some deeply touching patient stories. This is actually an electronic medical record snapshot note. This is a note that is in the record. This young lady, and this will tell you because as I passed through the halls and looked at Jackson Memorial, having trained myself at Kings County in Brooklyn as my first exposure to America 30 years ago, Jackson Memorial has always been in our psyche as a place at the University of Miami that was a salvage place for many, many medical surgical disasters. And early in my career, this is 2009, 8, 9, 10, a young woman was visiting Mexico and had a cholecystectomy done emergently, at least emergently on the eyes of the people who did it, and had a very severe and significant bile duct injury. The family was well resourced, and there's a family out of Rochester, but visiting Mexico. So they were able to somehow extricate her from there and airlift her to this helipad right here at Jackson Memorial, where this gentleman, who you're very familiar with, was part of the team that helped with a very long biliary reconstruction. When this patient finally was handed over to me, I had grown reading textbooks of Schiff's liver disease and known about Ted Zakis and the small bowel transplant here. And this was my first handoff from the University of Miami Jackson Memorial Hospital Center of Excellence in Biliary Surgery. She remained a very good friend of mine. She's still alive and doing very well. I had the great privilege of doing a couple of ERCPs on her. And as I was coming into this visit, I thought of this and a few other cases that I've had the great privilege of being part of. So people who are training here, who serve here as faculty, very, very proud to be here, with you and sharing this story. And you should feel very proud of where you work and what resource this campus serves, not just for the Americas, but for the continent and for the Americas as a whole. So just a moment of history there. Now, this is a topic very close to my heart. It is a topic that, of course, was very close to Dr. Barkin's heart as well. And that's why we agreed to do this, because in clinical medicine, and this is a Department of Medicine grand rounds, there are few topics that are still out of reach of a predictable outcome for us as clinicians. No matter how good a clinician you are, how good your ICU setup is, how quickly your ED functions, and how diligent your interventions and your thought process is. Severe acute pancreatitis with multi-organ failure and multi-organ dysfunction syndrome remains an elusive gap in clinical medicine with a fairly significant morbidity and mortality. And I think that for the young people here, the next decade hopefully will bring out similar progress that we've seen in other inflammatory states such as IBD and liver disease. So my charge here today is to speak a little bit to the overview. Really can't talk about a disease state without providing a brief synopsis of where we are currently, and then go through some of the very major high points of the guideline-based recommendations for management, and then leave you guys and gals with some thoughts about where the field is going in the future and where some research opportunities might exist. Now, because I'm a global person, as Jody mentioned, that's a kind of a tag that's stuck to me now. I almost always start any discussion with a global prevalence and a situation. So there has actually been a mild increase in the overall incidence of acute pancreatitis, with biliary and alcohol etiologies really standing out worldwide as well. In the US, the same situation exists. We have about 300,000 ED visits. It still remains one of the most important DRG diagnoses for hospital admission, and the cost is not insignificant. Significant costs at hospital stays and billions of dollars spent in healthcare dollars managing this condition. There seems to be a slight increasing incidence despite no significant improvement in outcomes for those who are struck with severe pancreatitis. So that's important to note. This is a very, very recent article. I generally try not to present data that's 10 years old. I was lucky to find this here. And if you look at the slides, basically telling you all patients' mortality and then broken down by gender. So in the last 20 years, we had a slight decrement with the advent of pancreatic stenting at ERCP, NSAIDs for ERCP pancreatitis protection. But in the last few years, it has gone up again in the post-COVID era. We're seeing more patients dying from it. There could be a variety of causes for it. We haven't fully explored it. But safe to say that the rising incidence has been well documented, especially in this particular paper that is a cumulative work across multiple studies and data points. The next thing to reflect upon is, well, what are the major causes? Because if we don't create a differential diagnosis when you see a patient with acute pancreatitis, we really cannot even start beginning to talk about treatment. So these are listed here. Alcohol and biliary etiologies are the two biggest ones, but there's a few others: hypertriglyceridemia, autoimmune pancreatitis, and a host of others that are listed on the right side. So by the time you're done with checking the boxes and all the etiologies that are possible in the physical world, there's a very, very small percentage of cases that are left that are actually idiopathic. So before you label somebody as idiopathic acute recurrent pancreatitis, make sure that we have looked at a lot of those ones, especially in the yellow. The hereditary pancreatitis genetic testing nowadays is much easier, much cheaper than it was even 5 years ago. So we need to think about those things as we see these patients in clinic or on the inpatient consult service. The pathophysiology of acute pancreatitis is very complex. I tried to simplify it here, especially in this forum, for general understanding, is that basically there is premature activation of trypsin, and that creates a cytokine cascade, which basically results in increased capillary permeability. And this is not mechanisms that are very dissimilar to severe sepsis, but there are some nuances here, and there is a significant amount of SIRS that is generated, systemic inflammatory response syndrome, from a non-infectious, literally non-metabolic type of etiology, and that's where the rub is. So a brief comment on that, but the actual mechanics of this are way more complicated and not necessarily within the scope of this talk. But what is within the scope of this talk is this particular slide. This is what we call the revised Atlanta classifications. Now, in the realm of the pancreas, we're not lucky enough to go to Rome and to other places to develop consensus statements. We can go to Atlanta, which is in the neighborhood, right? So this is the Atlanta classification. And note that this is a paper that was revised in 2013 in a top-tier journal, Gut. And this has remained the Bible for not only the diagnostic criteria for acute pancreatitis, but also for the different types of gradations of severity, including inflammatory pseudocysts, wall collections, necrosis, phlegmons, walled-off pancreatic necrosis. So if you open this article, you will have all the descriptory classifications that you would need to know, particularly as a GI fellow or as a GI attending managing these patients. But the most important thing that is relevant to everybody, especially to be stated at a forum like this where everybody is here. There's advanced practice providers, nurses potentially, internal medicine, GI, emergency room physicians may be listening in. This is the diagnostic criteria for acute pancreatitis. You have abdominal pain that is suspected to be of pancreatic origin, right? You have at least 3 times upper limit of normal for amylase and lipase. And remember, the upper limit of normal can be very different in Orlando for a lab than it may be at your lab. So pay attention to, in our own city in Rochester, we have an upper limit of normal that's 300. We have an upper limit of normal at strong, that's 64. So be very careful when you're doing these measurements. And of course, if you have an imaging evidence of pancreatic inflammation, that's a very objective sign. So any two of these three above criteria, and you have your diagnosis. The clinical presentation is also can be very varied, although the vast majority of patients will come in with abdominal pain and some evidence of a SIRS type response, whether it's mild, moderate, or severe. But as things get worse and you get the labs back and you get more information and clinical course gets worse, you will see severe hemoconcentration as one of the first signs of somebody who may not do so well. And next comes acute renal injury, acidosis, ARDS, and then the whole body fails. So this is kind of the sequence of events, and I'm very worried about a patient who comes in, receives a very significant amount of fluid at 12 noon, and at 8 p.m. tonight, after 5 liters of Ringer's lactate, their hematocrit has gone up, not even stayed the same, gone up. That's very bad news. That is a patient who is not likely going to do well. So at this level, when we have our residents and fellows looking at these patients, make sure that you pay attention to these lab criteria along with some others that I'll show you next. So these are the criteria associated with the severity prognosis of acute pancreatitis. They're listed right here. Patient who's tachycardic, borderline hypotensive or altered mental status, along with that, fever, severe leukocytosis, acidosis, all of that you've read about. A lot of scoring systems have been used over the years. There's probably at least 20 of them. I'm not deliberately presenting them here because this is what boils down to in the emergency room, in the ICU, and any other setting that you're seeing these patients. On the right side, of course, you have some lab parameters that I just spoke to, but in recent years, there has been a lot of talk about CRP as being a very important prognostic indicator. So if a CRP is on the low side at 24 hours, 48 hours, and 72 hours, you're more likely not going to lose that patient. That patient may be around for a few days or weeks, but they'll make it. But if you have a rapidly rising CRP or a CRP north of 150 on day 2, you got yourself a very significant problem. So incorporate this in your decision-making and evaluation. So stated simply, you have 3 boxes that these patients end up with in the first 24 to 48 hours. You have mild pancreatitis, moderate pancreatitis, and severe pancreatitis. And in the realm of consultative medicine and caring for these patients and providing some type of a prognostic recommendation to the patient, family, and to the referring providers, our focus is on the severe pancreatitis patient. The mild to moderate patient will do okay. It's going to be a lot of belly aches for the patient as well as the providing teams, but they will do okay. They will not die from it. But the severe patient will die from it, and that basically is heralded by 2 things. Number 1 is pancreatic necrosis, which means that the pancreas tissue is dying now, and the second point is multi-organ failure. Once these 2 things come in, the horse has far left the stable. And this is the area which we have not had a handle on, no matter what. I've seen many young people come in at 30 years old, hypertriglyceridemic. Even endocrine had a lot of challenges managing these patients over the years. Only now are they beginning to get effective treatments. It's hard for patients, young patients also, to comply with those type of follow-ups. So they come in with a triglyceride of 3,500, and they come in basically ICU to ICU. And there's not a thing we can do for them, even today at this point, because they're typically transferred at the point where they have already passed the 48-hour window. So that's a box that we need to talk about and focus on. That's severe pancreatitis. Not an option, and hopefully won't be an option because we will have some targeted treatments down the road. Red flags on admission, I already alluded to, but the SIRS criteria has really stood out to be the most practical, clinically actionable platform that we use on a regular basis. I had a patient, actually 2 patients yesterday coming into Miami. I told Dr. Barkin about it, both post-ERCP. And the only thing I was interested in last evening was to see what their SIRS criteria are. And luckily, both of them were stone cold normal in their vitals, and their labs were reflective of the same. One went home, and the other one is admitted. So these are the most common etiologies. I referred to it already. I think the important thing here for the gallstone biliary pancreatitis cases is once you manage the pancreatitis episode, you need to consider cholecystectomy on the same admission. But if the patient has severe pancreatitis, obviously that will be deferred. So you take care of the future episodes by taking care of the source. On the alcohol side, it's more complex, obviously, but it is now part of our quality metrics to provide alcohol counseling and to hook them up with rehab and such. Obviously, a much more complex issue to deal with, which I cannot get in too much, but safe to say that this is at least a third to sometimes even half of the etiological factors in communities across the world and in America. Obviously, a topic very close to my heart and to many others here who perform ERCP is post-ERCP pancreatitis. So this is the most common complication of ERCP. A lot of ERCP occurs in this system here as well. But in the last 20 years, we've made two very significant, three perhaps, significant progress in this realm. Number one, we do not recommend or do ERCP for abdominal pain only. We do it for stones. We do it for cancer obstruction. We do it for bile leaks. We do not do it for somebody coming in for abdominal pain. And that was the article, the episode trial that was presented more than 10 years ago. Number two, we found out also about 10, 12 years ago that rectal indomethacin is protective against severe pancreatitis. So that's a part of every naive or native papilla cannulation that occurs nowadays. Number three, we found out also about 15 years ago that pancreatic stenting applied prophylactically is life-saving in these cases. So now patients get ERCP for therapeutic indications, they get rectal NSAIDs, and they get pancreatic duct stenting when the operator feels that the pancreas has been manipulated too much and that post-ERCP pancreatitis is a virtual certainty. So it's very important to see that what progress we've made here. Now, what does it mean? It doesn't mean that we have completely eliminated post-ERCP pancreatitis. No, by no stretch of imagination. But what we have reduced very significantly is the occurrence of severe pancreatitis. So patients will still come in, they'll stay for a couple, 3 days, and most likely will go home within the week. So these are some of the key principles. We talk about prevention of post-ERCP pancreatitis. I talked about a couple of those. There are other nuanced and technical details at the procedure level, which I won't get into. But IV fluid hydration has been looked at. So they've done these mega boluses coming in, for ERCP. That didn't seem to pan out much. But in the high-risk patients, a head start. That is commonly missed our clinic visits. I can understand. Clinic visit, the whole purpose of an E&M visit is to have a detailed history and physical and medical history. I understand. Establish a temporal. The other good news is that there are only a few patients that are actually strongly correlated issues. All right. Issues are a part of my life, so here we go. There are only a very few actual medications, really the 3 or 4 listed here, that are actually have a strong one-to-one correlation with the iatrogenic development of acute pancreatitis. And this is something that you need to keep in mind. Fortunately, all of these medications either are outdated or have very good alternatives. Can anybody say how many blood pressure medications we have nowadays? Probably 750, right? So, but there are still patients in many communities who receive these medications, and these are easy fixes, if you will, but not unless you think about it and not unless you ask the patient, right? The second very favorite one for me is autoimmune pancreatitis. This is becoming very clear now in the realm of GI, probably in other disease states as well, that autoimmune disease states are more common than we think they are. Same for rheumatology, same in skin diseases, and same in GI, and same in cardiology as well. So unless you think about it and you ask the right questions, you get into the family histories, you ask about other systemic illnesses, you do the appropriate testing, you will never find it. So this is also a relatively easy fix. And now for the first time in 2026, we have an FDA-approved treatment for autoimmune pancreatitis and autoimmune cholangiopathy. And that is this drug here, inebilizumab Cdon, also known as Eplizna. And you'll hear more about this coming forward. It is not a cheap drug, but it is available now, and that represents progress for this population. But for the most part, these patients can be managed by prednisone and azathioprine. Here's actually an interesting case that reflects why it is so important. This patient was sent to me for pancreatic cancer. They said, this is a young man. He is 54 years old. Young is relative, right? So, and they said, well, this guy has a pancreatic mass and biliary obstruction. And we are sending him to you for EUS FNA, and then you can send him to Whipple, and life will be good. So I looked at this guy. I said, this doesn't add up. His CA99 is low or normal. Guy has no symptoms related to cancer. He's describing these weird symptoms that were developing for a couple of years. And he's sitting in front of me and looking at which surgeon to choose for Whipple. So we did the appropriate testing. We were able to demonstrate that he has autoimmune pancreatitis, mass-forming autoimmune pancreatitis, which is a special subset. We stented him, put him on prednisone, and that's his bile duct like 6 months later, right? So major impact, major impact. So what is the lesson here? Number one is that think about these diagnoses. They are there. Number two is that ideally, never send a patient to Whipple without a confirmed diagnosis of cancer or very high suspicion for cancer. Because if you have this or your lymphoma, you will look back and regret it a lot. Another favorite of mine is hereditary pancreatitis. Now, we have a pancreas cancer screening program. As I suspect, we have one here as well with Dr. Sussman. This is a difficult population because the lifetime risk for cancer pancreas is about 40% or more. But they also have another problem, which is how they initially present, which is recurrent pancreatitis episodes at a very early age. And sometimes, and many times, there are many family members, siblings who have the same problem. Again, I concede that genetic testing and access to genetic counselors was much more difficult back in the day. Not so the case now. These tests, in collaboration with our industry partners and really very high-end sophisticated labs that we work with now, including with the PRECEDE Consortium, which is a 29-country trial that Miami is part of as well. We have access to these tests, very easy access, either commercially or through research. In fact, on the last call, I was actually told, send us your patients and we will do them for free. I don't know if, Dan, you were on that call. So think of these. These are important populations. Patient keeps coming, young patient in the 15 to 35 age group. Think of this diagnosis. If you don't think about it, you will not find it. Now, pancreas divisum is a controversial disease state. It's a congenital abnormality where 5% of the world's population, which would be, I don't know, 7 billion people, 5% of that is 500, 400 million people, have this condition at birth. So if pancreas divisum was causing recurrent acute pancreatitis in every patient, I would never go home, right? So that's not the case. So, but for the first time, this is the anatomy of the pancreas divisum. The main pancreatic duct comes across, crosses the bile duct. This is called the crossover sign, and enters the region of the minor papilla. It doesn't enter the region of the major papilla. It's a very classic MRCP finding. So in the past, we were thinking that many patients coming with recurrent pancreatitis with pancreas divisum, we should do an ERCP and cut open their minor papilla. And sometimes, like Vegas, sometimes we won, sometimes we lost. And some patients died also. So for the first time, we had a trial that was conducted. This is the classic arborization pattern of the ventral duct when you shoot dye in it. So for the first time in history, we had a randomized controlled trial, sham controlled trial, NIH funded, that we were part of. And that basically was just presented in JAMA. And it basically said that in cases with pancreas divisum, normal ducts, and recurrent acute pancreatitis, ERCP provides no additional benefit over a sham procedure and may actually cause harm. So this is the type of research we need for other areas as well. This type of research is not traditionally been very common in endoscopy practice, but is becoming more common because we as a community realize that we need level 1 data to make significant, impactful practice changes that have a huge impact on patient outcome. So at this point, we are not offering ERCP for recurrent acute pancreatitis or pancreas divisum just off the shelf. There may be a certain subgroup of patients who have dilated ducts, obstructive disease, chronic pancreatitis, stone disease, strictures. That's a different discussion. But ERCP is off the table now. So that's the impact of clinical research, and that's something I wanted to show. There are some other causes of acute pancreatitis that are very important at a large referral center for trainees and young faculty to keep in mind, and those are listed here. A couple of them are very important, I think, because in medical surgical practice, they will be the cases that are discussed typically at, can you hear me now okay? Okay, yeah. They will be discussed at the case conferences, and one of them is groove pancreatitis. So this is groove pancreatitis, which is a very unique type of a problem. It's recurrent pancreatitis, and it has something to do with the duodenal pancreatic groove, which is an anatomical landmark, and the patient keeps coming back. Sometimes it looks like cancer, sometimes it is caused by an occult malignancy, but mostly not. And the treatment, it could be on the boards, GI boards, is a Whipple surgery. Very few patients actually are candidates for that for a variety of reasons. But the point is, this is a diagnosis that generally doesn't get talked about, but comes through the doors about 3 to 5 times a year or more at large referral centers. The other big favorite of mine, unfortunately, is where we actually had the opportunity to study this as well, is what is labeled as acute idiopathic pancreatitis in the older individual. And it's usually a mild pancreatitis, but actually is cancer presenting as pancreatitis. Now, it would be easy if your antecedent CAT scan or MRI actually showed you the cancer and the job is done. But these are those selected patients we studied, a few hundred of those over a long period of time. And we went back and looked at their CAT scans, normal or normal-ish, and then their EUSs showed cancer. But their original presentation was acute pancreatitis. So here's an example of that. A normal pancreas, right there, this is published, it's from our paper, and the same patient having an EUS showing a very discrete mass. So what is the take-home message here? Take-home message is that if we have a 5th, 6th, 7th decade individual, average risk individual, or even a 3rd, 4th, 5th decade individual who's higher risk populations, such as Lynch or hereditary pancreatitis or those type of syndromes, and the CT is looking okay, the patient has weight loss, CA19-9 is elevated, there's no mass to be found, send them for an EUS. At the worst, the EUS will be negative and you'll be back to square one. But at the best, you'll find an occult malignancy that would have actually come back and bite you in the back if you had missed it. All right? These are very easy legal cases, very easy legal cases, even though you didn't do anything wrong, but the opportunity was missed. And the cost of the missed opportunity is so significant that the legal jurisprudence system weighs in favor of the patient. So missed cancer is the number one, or delayed diagnosis of cancer, the number one litigation in GI medicine. And this is a perfect setup for that. So older patient with mild pancreatitis, no mass, EUS. And this is kind of our algorithm. It's in the paper. I won't belabor this, but for sake of completion, I showed it here. It basically says that if you have an unclear etiology of pancreatitis and a negative CAT scan, proceed with EUS. And if the EUS is not helpful, repeat the imaging. It's as simple as that. It's basically common sense, but you have to follow through that. And the system has to be set up that somebody is following these patients, whether it's a fellow, an APP, or a physician. You can't lose this person. Now, coming to the management part, which is really the core, this is just a slide to show how many guidelines there are. And in fact, one of the better ones recently is from the American College, but there's also from other societies, European, international associations, so forth. So when you look at management guidelines, regardless of how you get to the pancreatitis conundrum, these are the guiding principles. This is it. This is the center slide, money slide, whatever name you want to give it. At the end of the day, like I mentioned in the first few minutes, the goal is to have completely try to prevent multi-organ dysfunction and organ necrosis. If you avoid those two things, and organ necrosis comes first and the MODS comes after that, then you're okay. You still have a lot of morbidity to deal with, but you're not going to lose the patient very likely. How do you get there? Is by the main tool we've had all these years, which is goal-directed fluid therapy. Now, this is a confusing term for the uninitiated. I'll get a little bit into it, and we will talk about that. The other thing is to really follow guideline-based. Why is it important? So you get a person who's got abdominal pain and a lipase of 16,000. You don't need a CAT scan to diagnose acute pancreatitis in the ED. But guess what? They're all getting it. Now, not only do you have a person who's intravascularly depleted, already heading to AKI, now you gave him a huge contrast load, delayed his care, now he has AKI and a delayed fluid intake. So congratulations, all right? Same way with nutrition. TPN gives you infection, well documented. Enteral feeding reduces translocation of gut bacteria, right? So big practice changes in some communities, but this is the data. This is where we are at. Antibiotics have no role unless you have proven infection. So that's the slide. Now, in this particular construct, I'm trying to show that how we actually follow the patient. The patient is seen in the ED, they made NPO for bowel rest is very important right in the moment. And we go with goal-directed fluid therapy, which is weight-based. We obviously take care of pain because pain also contributes to the vicious cycle of patient not well-being. But clinical and hemodynamic monitoring is extremely important. Remember the SIRS concept? And then you start looking for the etiology. Because if the etiology is biliary pancreatitis and you have a stone stuck at the ampulla, that patient is not going to do well how much fluid you give him. That person needs an ERCP, for example. The nutrition has to be enteral, however you get it. And that's the data. And that's actually also a board question in the GI boards. The answer will be feed the patient, okay? And then, of course, to prevent multi-organ dysfunction. Now, several years ago, I had a very diligent fellow, advanced fellow, John Miller. He now practices in Springfield, Massachusetts. But John was a bright guy, and he kept coming back to me like, this patient is not doing well, this patient is not doing well, they didn't give the fluids, they didn't do this. I said, John, let's sit down and figure out how we can fix this. So this was about 7 or 8 years ago. I'm fuzzy on the time frame. But John and I, we kind of created with the help of many, many people in the division and in IT department and all the people who approve EPIC protocols, this protocol. So this is our university kind of protocol. It's now an EPIC order set. So patient comes in, the initial assessment. At the time, before the waterfall trial, which I'll show you next, this was the kind of the dosage that we had, 20 milligram per kilogram body weight for bolus, 3 milligram per kilogram for our maintenance. But the key point, which the waterfall trial also finally in the New England Journal pointed out, maybe like 7 years later, is the initial assessment at 6 hours. No algorithm had that before. We introduced that. And based on that, we said, if the patient is doing well, we will cut down the fluids. The patient is not doing well, we will maintain or do something different. And you can see here my initial comments on the hematocrit and BUN. When they go down, this patient is responding. It's as simple as that. You don't need no Apache or nothing. This is it. And of course, if you have volume overload, you can manage that. Remember our friend Lasix? No, we don't use Lasix, something else perhaps, because Lasix can also cause pancreatitis. But the patients who are not responding are in the red box. Their BUN goes up, their creatinine goes up, they're hemoconcentrated, they look toxic, they're not going to do well. So do something different for them. And then, of course, in 2022 came the waterfall trial, published in the New England Journal, which basically looked at the question, how much fluid is too much fluid? And they basically came to the conclusion that for moderate, severe, or severe pancreatitis, it may not be a good idea to use a blanket 20 milliliter per kilogram dose. Most patients will be okay with the lower dose, 10 milliliter, and the 1.5 maintenance. So now the standard approach is to go with a moderate fluid resuscitation because you get the best of both worlds. You get prevention of pancreatic ischemia and necrosis at the sweet spot, and you get less fluid overload and morbidity. So this was the message from the waterfall trial. There's many, many trials in fluids, but I tried to bring it down to that core message. But look here, they also had an assessment at 3 hours. Very important. And the problem is that in our current system, it's very difficult for any entity in the system to ensure that you have such regular follow-up. the level of care needed in the first 12 to 24 hours, I suspect, is beyond the capabilities of most systems, which is why we still have a gap. But if we were to do it, I think the outcomes will be much better. So here is the aggressive IV fluid. You have a very significant morbidity with fluid overload, very significant decline in that when you go with the smaller fluid paradigm. These things should be imprinted in your memory when you go see these patients, because that's really what the message boils down to. So a lot of good work there. I already referred to the nutrition concepts. It's as far as possible, use the gut. And this goes for like the smoldering cases where they end up with GJ tubes, much preferred over TPN because TPN is artificial and creates more problems. Antibiotics, clearly stated, not to be used empirically. If you have a biliary sepsis, if you have pus coming out of a drain, if you have gas forming in a collection, yes, of course. But every patient coming through the door with a white count, no. Etiology specific recommendations are listed here. Obviously, they are somewhat intuitive, but I already referred to some of the more important ones, such as the emphasis on laparoscopic cholecystectomy in the vast majority of patients in the same admission, and if not, in the 30 days, and if not, absolutely in the 60 days. Beyond that, we have shown, and others shown as well, that the outcomes can be very bad because they come back with recurrent disease. This is that paper I was referring to, the timing of cholecystectomy. This is a very, very hot topic in the last few years. Really should be performed in the same session, if possible. Obviously, when you have significant intra-abdominal inflammation or sepsis, that would not be a good idea. But fortunately, those are not the majority of the cases. So kind of summarize the do's and don'ts of acute pancreatitis management, all guideline-based recommendations here. Very little to none of this is actually consensus opinion, which is a great place to be. There are not a lot of places in medicine that you can say that their entire slide is 11-1 RCT. That's really a big statement, right? So early recognition, goal-directed fluid therapy, nutrition, which is enteral, and avoidance of unnecessary imaging and antibiotics really is the key. Complications, there's as many complications as you can imagine. Some of the early ones, of course, are necrosis and organ failure, and then that leads to fluid collections, compressive episodes, compartment syndromes, abscesses, infected abdomen, and many other systemic issues. Pseudoaneurysms also are a big problem. So if you see a pseudocyst in clinic follow-up and you have a branch of the splenic artery like just kissing it over there, do something about it. Ask the vascular people, ask IR, is this somebody you would like to take care of, or should we wait for the catastrophe? Those questions have to be asked, because when they present with an abdominal catastrophe and they look back 3 months ago and they had this problem, you will be very defenseless at the time. A very short note on pancreatic pseudocyst management. At this point, this is a paradigm that has been taken over from surgery to endoscopy, and the surgeons are very happy about it. If there was one surgery they wanted to give up, it was this one. So with endoscopic ultrasound, we are able to drain these very effectively and safely. There are still complications, but we are able to do both drainage as well as necrosectomy with a fairly predictable outcome in the vast majority of cases. You can see a huge cyst here. 4 weeks later, it's drained, and then several weeks later, it's almost gone. The management of these is a separate topic in itself, but I just wanted to highlight that. This is also a major advance in clinical medicine. This is the so-called lumen opposing stent, which brings 2 disparate lumens together and seals them together for the most part. And Dr. Ken Binmoller, a great friend of ours, was involved with the development of this device, and it's now used worldwide with, if not million, but several 100,000 use case scenarios and across 100 countries. Now, the final couple slides, unmet needs in acute pancreatitis management are listed here. I think for me, number one is the opportunity where you have a high-risk individual who's either set up for recurrent pancreatitis episodes or already has had a few, and you are missing a treatable cause for acute recurrent pancreatitis, such as autoimmune pancreatitis, such as a patient who has a cancer, let's say, occult malignancy, or some other type of phenomenon that could be treated. The second is in the early phases that we do not still have targeted therapy to obstruct the cytokine cascade. That's very important. The third area is to really increase awareness around the fluid management. There's been a lot of confusion on this because there's been as many papers as you can think about, do this, do that, do this, do that, and even the waterfall trial presented positive outcomes for pancreatitis with both the groups. But if you read it carefully, only then will you understand that the lower fluid level is probably the better approach. And so the more we talk about it, the more we educate our APPs, our ED residents, our own residents and fellows, and our faculty who are rounding, the more likely we're going to have an appropriate, what I call the door to fluid time, almost like the door to balloon time in cardiology, and probably have better outcomes. And I already referred to the nutrition related challenges. Now, one of the last things is patient-reported outcomes research. And this is something very important in clinical medicine today in general, but it's also very important here. So I'll go through some of the targets that have been used. This is a relatively ongoing recent trial that is enrolling at this point. This is a CRAC channel inhibitor drug. So stuff like this going on, which is targeted therapy, looking at CT scan indices for inflammation. Again, we don't know the outcome of this yet, but what the idea here is that you'll have a decrease in the initial ARDS component and decrease in initial necrotizing pancreatitis episodes. So hopefully in a couple of years, we'll have an idea of where this is going, but it's a proof of principle application, which is still not done yet. Here's another recent study that basically looked at a drug called pirfenidone, a randomized double-blind controlled trial. There are 3 participating sites in the US, which are all the major sites, and looking at just the feasibility and safety of this drug and looking at secondary endpoints, which are listed here. Again, early data to suggest that there might be something here, but nothing conclusive that by any stretch of imagination has made it to the mainstream. But this is the direction we're kind of going. As you can see there, the green box suggesting that we're still recruiting here and looking at safety and feasibility. A study that has been done is a patient-reported outcome study. That was the PAN-PROMISE study. More of this needs to happen, where basically the patient wellness, patient's symptomatology through the treatment journey was being recorded as an outcome. And you can look here that in patients who had mild, moderate, or severe cases, the patient-reported data is reflective accordingly. So while we are using hematocrit and BUN and hemodynamics, if we are paying attention to some of the PROs, that might also help us triage these patients more effectively. So it's all adjunctive, it's all complementary, it all adds to our knowledge base in the first 24 to 72 hours. And you can see here at 15 days, it's all a level playing field because everybody is kind of sort of doing well or has come to a baseline state of health. So very, very interesting data that came through in the PRO study. Now, there's a host of other emerging therapies, mostly related to targeted therapies that are listed here, obviously beyond the scope of my talk to get into the details. But the concepts that we had from cancer medicine, from IBD therapy, are being applied here as well to take a specific action point in the cytokine cascade and try to impact that through a variety of trial and error mechanisms, usually developed in the lab and then brought to what we call human trials. So more to come on this, but I am looking at this in the next 5 to 10 years as being the final holy grail where we will have a solution for this problem as well. AI models are being developed. I don't think that of all the things where I need AI to help with, the diagnosis of acute pancreatitis in the ED, based on the criteria we discussed, it should not be a mystery. But I do feel that some of the cases where you have occult neoplasia or some other random anatomical issues that are contributing to it, or if you need to collate history more efficiently and bring multiple imaging studies together for input, there may be a role for AI there as well. Last few points. This is again a kind of re-emphasis on the fact that there are really no current drugs available to target early inflammatory cytokine cascades. We do need to manage pain and look at patient-reported outcomes through the early treatment journey. We need to emphasize goal-directed fluid therapy, maintain nutrition through the enteral routes as best as possible, bring a multidisciplinary input to the really severe cases, use endoscopic therapy where appropriate, and step up the therapy to IR and rarely to surgery if needed, and really try to save these lives and make a difference. So for me, the initial door to fluid time is very, very, very important. These patients should not sit in waiting rooms hanging on to an IV pole that doesn't have a bag. Even if they're going to, in our EDs, sometimes they are in the waiting rooms, but they'll still hook them up to an IV bag. They need recurrent, careful assessments. You reserve CAT scan and imaging and endoscopic therapy for specific indications, and you rule out cancer when in the appropriate patient where there is a suspicion for that. Now, the final word here is that in really, this is a disease state that lends itself to management probably best at centers that have a lot of experience with it. In most communities, there is at least 1 or 2 or 3 such ivory towers or beacons that end up receiving the referrals for complex care of these individuals. And I think that's okay. And that's also opportunity for us to enroll them in clinical trials whenever feasible. So with that, I'll stop, and hopefully this was not too bad. Thank you.
That was an understatement, Dr. Kaul. It was excellent, not too bad. So if I could begin by asking the first question. We've now entered the era of GLP-1 agonists, and if there's a fair number of patients who present with elevated lipase and amylase. And so I don't know if they reach the criteria of 3 times the upper limit of normal, but some do. And the question is, do you stop that medicine, assuming they don't have a gallstone as another cause for the elevated enzyme?
Right.
And is there a way to select which patients are likely to get it before you put them on the medication so that you can avoid it?
Yeah, so GLP-1 is there like from breakfast to dinner. That's all I hear anymore, right? So thank you for the question. That was a pun intended, right? It's meal related. So the short answer is that there was a recent FDA advisory on some reported cases of severe pancreatitis related to one of the products. I won't name the product. So when patients are asking us left, right, and center, can we go on this? I think at this point, we can say they're mostly safe, especially from the pancreas standpoint, but you have to counsel them that there were a few cases that the FDA has put out an advisory on that. So that's the most recent information I have on that. Specifically to your question, patients may have transient transaminases or lipase amylase changes from a variety of medications. We saw that also with statins when statins first came, and there was a guidance to follow them. I am not aware currently that if an amylase or lipase abnormality is the only prevalent abnormality.
And pain.
And pain, then at that point you have to take it seriously. If you are meeting the revised Atlanta criteria for pancreatitis, then you need to have a visit with the patient and discuss what's going on. That is probably a patient I might image actually to see if there is actual acute pancreatitis developing, or is this peptic ulcer disease with some concomitant abnormalities or some other pathology.
Image how?
Typically with a CAT scan in today's day and age for that particular patient, because the diagnosis is in doubt.
Identify.
Thank you very much. Thank you very much for the presentation. My name is Daniel. I'm one of the residents internal medicine third year here. You did a good job at explaining some of the people I would be worried about when I admit to the medicine floor from the emergency department. I'm checking their labs after 6 hours, seeing that their ICRP or their hematocrits going up. I just wonder at that point, what am I going to do differently? I'll be doing 10 milliliters per hour. They got that in the ED, and there'll be a 3 per hour per kilo. Do I double the dose on it? Do I just put them a little closer to the ICU, or what should I be doing or looking out for in those scenarios?
So that's a good question. Obviously, we cannot discuss here today specific case scenarios, but the most important thing is that you are going and checking that patient. And one of the things that you're doing at that visit is looking for fluid overload. And most patients will have some bilateral basilar crepitus. That comes from with part of the atelectasis and all that. But I think as you grow in your training and you get more experience with this, you will be able to tell which patient is either not doing well from fluid overload or not doing well from a surge perspective, or both. And that's where you raise the escalated discussion. And you know what? In clinical medicine, you're allowed to be wrong when it's in favor of the patient. But if you are saying that, well, I'm looking at this patient, he doesn't look well, I'll come back in another 12 hours, and in the meantime, the patient crashes, you'll feel very bad about it. So I think probably not a very sharp answer to your question, but I think that the most important thing is you're looking at the patient and you will be able to assess which box that person falls in. If in doubt, move them along to a higher level of care. That is the entire purpose. You will not be able to answer all the questions related to the patient's destiny, but the touch point is the first point. And from there, you take it.
Yeah, hi, very nice talk.
Thank you.
My name is Dr. Kolber. I'm one of the Department of Medicine faculty. My question has to go back to the fluid management because looking at and multiplying the numbers in kilograms of people I usually see, and I'm an old timer, let's just word it that way, of the school where fluids are good. 1.5 milliliters per kilogram per hour is not a lot of fluid in my book.
Correct.
So at most 150 cc's an hour, which,
Correct.
to be honest with you, I'm used to giving 125
Correct.
routinely. So we're not talking a huge amount
We are
of
not.
fluid.
We are not. But I'll let you finish if that's a.
Well,
Yeah.
my question is I thought the whole gestalt behind here is to make sure we're giving fluids. And to me, this is not an extraordinary amount of fluid.
Correct. I completely agree with you. But you know what? There are two things here. Number one, what happened, and the reason this question came is because fluid, and people were giving a lot of fluid. There was no measured way of giving the fluid. There was no structure to it. So the question came to the study. Now the study is the study. Now, does the study reflect all patient populations? Does it reflect every clinical scenario? Does it correlate with every clinical practice paradigm? No. And that's one of the distinguishing features of and again, nothing against the NEJM or the annals, but that's why pragmatic trials were created in medicine, because these pragmatic trials are real world trials, and that has not occurred yet to my knowledge. So you take it with a grain of salt. Yes, it's not a lot of fluid, but I think the purpose of the study was to look at what is the sweet spot between maintaining what your practice is and saving the patient from a pancreatic catastrophe, but also minimizing the fluid overload and the cardiac compromise. So I think that's where the message was.
And last question, Dr. Gershengorn, if you can unmute yourself and ask your question online.
I will try, Dr. Weiss. Can you guys hear me okay?
Yeah, perfect.
Excellent. Yeah, no, thank you so much for the talk. I really appreciated your sort of focusing in on the things that we really need to do. And one of them, which I think we've been hearing for a long time, is not prophylactically or early on giving antibiotics. I feel like I've known that since training, which now is longer ago than I would have wanted it to be. But nonetheless, I see that antibiotics are almost always given. And I'm just wondering if you can speak to if you've been successful in not having programs not give it. Talk to how you've been able to make that happen, because I think it goes against most clinicians' guts when they see a febrile person with a white count who's tachycardic. And trying to change that has been hard in my experience.
Right. So it's a great question, and again speaks to the realities of the real world, right? So the initial answer to that is that charity begins at home, right? So the first thing we do is that we bring our house in order best we can. Now we are a 1,400 bed hospital, one campus, a lot of activity going around. So I'm fairly certain nothing is 100%. But through our rounds, through our education, through our conferences, through our multidisciplinary discussions, through our discussions and handoffs and communication with our referring providers pretty much every day, when you repeat this often enough and you emphasize on it and you hold your ground, practice changes. It does change. Whether it is every single touch point, I guess not, but it does over a period of time change. And that's why somebody like me, like if I'm given this opportunity, I didn't go too much into the Lancet level pathophysiology of pancreatitis, because that's another forum. This is the forum where we need to talk about how do we implement guideline-based recommendations into clinical practice, and I think that's why I talk about it.
Thank you very much. It was excellent and very articulate and important. Thank you for this grand rounds.
Thanks.
I want to make mention, first of all, again, to thank Dr. Barkin, Jamie, who is, I know, online and in the audience. Jamie, we wish you good health and continue to be the longest living gastroenterologist in the division for many years yet to come. I want to thank the donors who made this lecture possible, and want to remind everybody that the MEC and MOC credits are available in the QR code as you leave the room or online in the chat. At this point, though, I want to invite the son of, he did not say it was his father, but it is his father in case you didn't know, Dr. Jody Barkin, to give a plaque of appreciation to our speaker today, Dr. Kaul, and congratulate him for giving the Jody Barkin lecture, the Jamie Barkin lecture. So thank you all, and have a great day.